Hi everyone and welcome to day 9 of the 10 on 10 series. So in the next 2 days we are going to have PYQs, which is also nearing the end of this series, and to add on to it, instead of 10 I think we'll discuss 15 each. Because these are PYQs and extremely close to the FMG exam first, so I've kept the previous year questions of the FMG exam in this, which is going to be beneficial both for FMG and NEET PG students. So starting with pathology today, but before that the homework of the previous class was the coccidian parasite that you had to identify, which was an oval shaped oocyst that was of isospora. The size of it that I asked you, as correctly mentioned by all of you, is 24 to 36 microns, and the treatment of both the spora brothers, that is cyclospora and isospora, happens to be cotrimoxazole. So perfectly answered as always by all of you, and let's begin with this. So starting with the first question, which is a 30-year-old patient over here coming with an unsteady gait, forgetfulness, labile moods, which tells us about a CNS involvement, and the Kayser-Fleischer rings tell us clearly about the copper overload and the Wilson disease. The question is about the gene which was asked in the previous year and the chromosome on which it is present. So it is the ATP7B gene which is going to be present on chromosome 13, which is the answer over here. And we are starting our today's session with a homework where you are going to tell me that where do we study ATP7A gene mutation. That's the first homework for the day. But meanwhile, in Wilson disease, which is known as a copper overload, it is the ATP7B gene mutation which is going to be present on chromosome 13. And now over here, the copper goes and gets deposited in three particular organs. One is the liver, in which there can be cirrhosis of the liver. One is the brain, because of which you could see the symptoms in the patient. And then of course are the eyes, in which there is going to be the Kayser-Fleischer ring, which we all know is getting deposited, and I'm not writing it because you know it from ophthalmology. The copper is getting deposited in the descemet membrane of the cornea, thereby resulting in the KF rings. Now obviously another question that comes is, what is the special stain for copper, which I think we have revised it a million times earlier, that copper ends with R and the names of the stains are going to be rhodanine as well as rubianic acid. And I hope you did not confuse this with rhodamine as always, and I have to make you revise this once before the exam one last time. Rhodamine is going to be for Mycobacterium TB and is different. M for M, rhodamine for Mycobacterium TB. This is rhodanine, which is going to be for copper. Moving on to the next previous year question in August 2020 is, which enzyme is responsible for the immortality of the cancer cells, or immortality in general, whether it is the immortality of our normal cells or of the cancer cells, it is always telomerase. The reason that we are aging, or any cell would age, is that the telomeres, not telomerase. I'm saying that reason we are aging is that the telomeres are shortening. So if this is a chromosome, telomeres are present over here, and these telomeres are becoming shorter and shorter, and that is why we are becoming old. What can prevent this shortening is going to be the telomerase enzyme. So the telomerase enzyme will prevent the telomere shortening. It will not let the telomeres shorten, and that is why it will not let us age. And this is what is exploited by the cancer cells. Cancer cells know that if they want to remain amar and immortal, they should use telomerase, they should increase telomerase so that the telomeres are not going to shorten and then they can live forever. However, there's another option given over here, that is helicase, which gets a previous year question. Helicase enzyme defect, especially DNA helicase defect, has been associated with a premature aging syndrome or progeria syndrome known as Werner syndrome. This was a NEET PG PYQ that has been asked. Moving on to the next question over here, another August 2020. Macrophages play an important role in phagocytosis and chronic inflammation. We know that. Which of the following cells perform the same function in the liver? Nowadays, similar questions are coming as match the following. So in the liver, this is going to be the Kupffer cells. I have a lot of other cells written over here, like hepatocytes, sinusoidal cells. These are all to do with the liver. So why not quickly revise the liver and also give you homework 2 for the day? So what is this to do with the liver that we are seeing over here? Firstly, what you have as these, what in the center is of course going to be the central vein. The periphery will have the portal triad. Now between the central vein and the portal triad, you can see these cords going, and these are the cords of the hepatocytes. So if this is one pink color cord and another pink color cord, supplying blood to them in between are going to be the sinusoids. And do you know it is in the wall of these sinusoids that the Kupffer cells are going to be present. So macrophages of the liver called Kupffer cells, I'll label them as a star, are going to be present in the walls of the sinusoids. Now, let's look at the space. If I have hepatocyte on one side and sinusoid on the other, there is a very tiny little space that I can see between them that is known as the space of Deci. And this space of Deci now has two very important things as PYQs. Number one, the amyloid deposition first in the liver occurs in the space of Deci. And second are the cells that are found over here. They are known as the ito cells or the stellate cell. So when you talk about their names, they are the same cell, but their function is different. So when they are in the resting stage, we call them the ito cell, and they are going to do the vitamin A storage for us. Whereas when they get activated, they are going to be known as stellate cells, and now they are going to lay down collagen type 1 and 3 for us. This is what you see in cirrhosis of the liver. So please note, they are the same cell present in the space of Deci. Like you are the same person, but till 6 months before you were in the ito cell stage where you were sleeping and eating and storing all vitamin A. But now with less than 1 week left for the exam for most of you, whether it's FMG or NEET, you've become into an active state of stellate cell, and now you are studying everything left, right, center. So now you're laying down a lot of collagen, that is collagen type 1 and collagen 3 in the liver. So now the question, which is homework 2 for the day, is that where are the canals of herring and which is the cell related to the liver that is present in the canals of herring? So that's homework number 2. But before that, and moving on to the next question, Kupffer cells are the macrophages in the liver, which makes us go to the next match the following, which every macrophage of every organ needs to be revised. So in the brain, it is going to be the microglia, because glial tissue will always be reminding me of the brain. Then for lungs, it is going to be the alveoli, so alveolar macrophages, which have all the dust and carbon in them, so dust cells. Liver, I just now told you, are the Kupffer cells. Talking about kidney, kidney has mesangium, so mesangial cells are macrophages. In the spleen, we had always learnt it as spleen, LE, so that is going to be littoral cells or littoral cells. The placenta is very important, that is going to be the Hofbauer cells, and there is one virus which goes and attacks the Hofbauer cells when the mother during her pregnancy, and that is going to be the Zika virus, which has been a previous year question also. In the bone, the macrophages are known as osteoclast, and in the synovium, they are known as the type A synoviocytes. So these are all the macrophages that could come as match the following in the exam. Moving on to the next question now, and that is to do with no question at all. I wanted to make you revise the outline, so I didn't put up a question and a direct spotter, because you know one outline usually comes. So one of them is known as the Reed-Sternberg cell and the other one is the cytomegalovirus. The method of identifying: in the Reed-Sternberg cell of Hodgkin's lymphoma, the color of the eyes is going to be pink, and in cytomegalovirus, the color of the eyes is going to be blue. So the color of the inclusions is what we are talking about. The next question over here is from 2018, long back, and that is, which of the following is the most abundant glycoprotein in the basement membrane? I've seen a lot of students getting an error here, and hence I've got it, because they read basement membrane and all that they want to look out for is collagen type 4, which is not even there in the options. So now they've asked you for the most abundant glycoprotein, and that is going to be laminin. Because if they would have asked you the most abundant collagen, then your answer of basement membrane would be collagen type 4, but here it's not the question asked. Here the most abundant overall glycoprotein, even more than collagen, has been asked, and the answer is going to be laminin. Moving on to the next question, an FMG favorite, that is to do with the cell cycle. I hope you remember the sequence of the cell cycle also. It is G1, S, and then G2, and then M. So G1, S, G2, M. And where are the two checkpoints present on the cell cycle? The first checkpoint is at the junction of G1S. The second checkpoint is at the junction of G2M. So why is it always going on in this G1S, G2M? What are the cyclins that are helping? And your favorite mnemonic and cricketer, that is Dhoni ek acha batsman, which tells us the sequence is cyclin DEAB. Option B is the answer over here. So cyclin DEAB is how it works, and every cyclin has to work with CDKs, cyclin dependent kinases. So with Dhoni, I will always keep the 4 and 6, so CDK 4 and 6, and with others I will keep double, and single runs. So with cyclin D, it is CDK 4 and 6 working. With cyclin E, it is CDK 2. With cyclin A also it is CDK 2, and with cyclin B, it is CDK 1. So rather than that, we learn it as DEAB, and then we learn the numbers accordingly. Moving on to the next question. It's a lengthy one but rather simple, and this came not only in FMG but also in INI and NEET PG. So here we have an elderly male patient with fatigue, breathlessness and palpitations, no comorbidity, no smoking or drinking. On examination, pedal edema and vitals are also mentioned. The pulse rate is 55, BP 170, SpO2 94%. ECG was taken, no abnormality. He was given oxygen and an echo revealed restrictive cardiomyopathy, and after telling us so much, they have finally come to the diagnosis themselves. So now for restrictive cardiomyopathy, there was a cardiac biopsy done which is showing us apple green birefringence. Sometimes reading it in reverse and retrospective actually saves you a lot of time. As soon as I would have read polarized microscopy and apple green birefringence, there is no other way, and there is no way that I'm thinking of anything else. It has to be a cardiac amyloidosis, and also cardiac amyloidosis is the most common cause of restrictive cardiomyopathy, as we know. And when I say restriction, it is a restriction of what? Is it a systolic dysfunction or a diastolic dysfunction? A medicine question, it is a diastolic dysfunction. Apple green birefringence, polarizing microscopy. Because we are talking about amyloid, your next question is to do with amyloid and a PYQ, which says which is not seen on the electron microscopic appearance of amyloid. So do you see non-branching fibrils? Yes, these are fibrils. Do you know their length? No, they have an indefinite length. Do you know their diameter? Yes, it is 7.5 to 10 nanometers. The diameter is known. So which is not seen on electron microscopy is beta pleated sheet. But you will say, ma'am, amyloid shows us beta pleated sheets, but that is not seen on electron microscopy. Beta pleated sheet configuration is going to be seen on a technique that is known as X-ray crystallography. Let me quickly make you revise everything to do with amyloid. Whenever we talk about amyloid, the gross appearance is always waxy. Like over here, kidney is there, so it appears like candle wax. Waxy word will always tell us amyloid. And with every time I say stain, you're like Congo red. But look at the question I'm asking you next. What is the stain that you will apply on this kidney? Means I'm asking you for a gross stain, and now the name of that stain is going to be Lugol's iodine. Versus I ask you what is the stain you will apply under the microscope? That is Congo red, and I'm not writing it. Is obvious that you are going to get the apple green birefringence on polarizing microscopic examination. However, the other PYQ was that if you are using ultraviolet light, now which stain will you use for amyloid? So you will use thioflavin T. So TUV, thioflavin T, I will use UV light. Moving on to the next, on electron microscopy, that is the question asked over here. We see non-branching fibrils. I don't know their length. They have an indefinite length, but I know their diameter. It is 7.5 to 10 nanometers. And what do I see on X-ray crystallography? We see the beta pleated sheet. So what is not seen on electron microscopy is option C over here. Moving on to the next question, another FMG exam favorite. What you've already gathered from here, I hope, is a pink color keratin pearl. And whenever we see these KPs or keratin pearls, they have a mass in the obstruction in left mainstem bronchus. They're talking about a lung cancer. They have a very strong history of smoking. Now with smoking, I either think of squamous cell, usually, I'm not saying always, but we think of squamous cell carcinoma and small cell carcinoma. And with keratin pearls, we have obviously thought of squamous cell carcinoma. They are saying immunohistochemical expression is what you have to tell me. For squamous cell carcinoma, the two markers in the lung are P40 and P63, out of which P40 is said to be the best, and that is most likely to show a strong expression of P40. Even by other options, when I look, napsin A, MUC1, TTF1, all these A and 111s were going to be for adenocarcinoma of the lung, which is very important. So one last time, we quickly revise all the immunohistochemical markers of the lung tumors. Firstly, which is this? The KPs, the keratin pearl. So this is squamous cell carcinoma. In the pearls, the P40 and P63 will come positive, out of which FMG exam question, P40 is the best. Now when I start seeing these round glands, that of course is adenocarcinoma, and the brown color staining is what I'm talking about over here. That is immunohistochemistry, always gives the brown color. So A for adenocarcinoma, we think of napsin A, first alphabet, MUC1, TTF1. Now comes the chota packet bada dhamaka, which is the small cell. The list is endless. So now, why did I call this small cell? Because I can see that there is a blood vessel which looks like everything but blood. It's a blue color blood vessel known as Azopardi effect, which you see in small cell or root cell cancer. For FMG exam in January 2023, they asked you synaptophysin and chromogranin, and that much is enough for the exam. Synaptophysin and chromogranin are markers of small cell, but for NEET PG, you have to learn all 7. So first you learn it by in. That is synaptophysin, chromogranin, and bombacin are the first 3 markers. Then you come down to all the short forms like NSC, INSM, which was the last year INI-CT question, CD56 and CD57. So NSC, INSM, CD56, CD57. The INI question last year was which out of these is a new nuclear marker for this tumor. So nuclear marker, students had never heard of it. All of us were not expecting such a vague question to be asked, but students took a safe guess and they said, okay, intranuclear marker must be intranuclear, although INSM does not stand for intranuclear, and you don't have to know the full form, but sometimes you just have to take a vague guess, and sometimes it does work in your favor. So you have in, and then you have the four short forms for small cell carcinoma. Moving on to the next one is a brain tumor. Patient has seizures and muscle weakness, but there is no other neurological sign. CT scan shows a mass in the left cerebral hemisphere, and a left craniotomy of the frontotemporal region is done. You can see the classical serpentine necrosis, and around the serpentine necrosis you can also notice how the tumor cells are sitting. So that is known as the pseudo palisading of the tumor cell, making it a glioblastoma. What is it also known as? It is also known as a butterfly glioma, because very commonly it is seen on the left and the right side. It crosses the midline, and hence a glioblastoma. Genetically, I hope you remember that most commonly it shows the IDH wild type genetics, and then next of course is going to be the IDH mutant type. Now when I move on to the other question related to it is, what is the WHO grading of astrocytomas, and which grade does glioblastoma fall under? Whenever I say glioblastoma, I always say glioblastoma, medulloblastoma. That means bomb blast in the brain. It's going to have the worst prognosis, that is grade 4. Now I want all of you to revise what exactly is this WHO grading, which was initially known as the Saint Anne Mayo grading, still known by this name. It divides brain tumors from grade 1 to grade 4. Grade 1 of course has the best prognosis, and in common sense as we move towards grade 4 it becomes very, very bad, and that is based on 4 criteria which we had learnt by the mnemonic AMEN. Let's revise those criteria. What does A stand for? Atypia, more important for NEET PG students. A for atypia, M for mitotic activity, E for blood vessel, that is endothelial cell proliferation, and N for necrosis. So AMEN, when nothing is present out of AMEN, it's a good tumor. No atypia, no mitosis, no endothelial proliferation, no necrosis. When only atypia is present, it is grade 2. When atypia and mitosis is present, it is grade 3. And when out of these 4, even if any 3 are present, that is going to be a grade 4 brain tumor. So repeating, nothing is present, grade 1, only atypia, grade 2, atypia and mitosis, grade 3, and out of these 4, any 3 also present, that is going to be grade 4. So glioblastoma or anything blastoma is grade 4. Moving on to the next question, FMG exam again, and a much expected question, where you have a 30-year-old male of fatigue complaint for the past 1 year and a massive spleen. If it would be infective etiology, I will think of Kala Azar. If it's something to do with leukemias, I can think of CML, but let's see further. The blood workup says that the patient has anemia. The TLC, which is supposed to be between 4,000 to 11,000, is nowhere in thousands, has gone up to 1,50,000, which is of course a blood cancer. Peripheral smear shows us there are 60% neutrophils, there are basophils, there are eosinophils, myeloblasts, myelocytes, and metamyelocytes. So I can see a full garden party appearance happening over here. There's a mix of cells, and that obviously makes it a case of CML. Whenever I will see this college girl or garden party appearance, where I can see, and if it's not written like this, because I can see mature neutrophils, and then I can see the precursors of the neutrophils also mentioned. So this will be written as shift to left. Whenever they write shift to left, they want to tell you that the precursors are present. That will also indicate something to do with CML. We all know CML is Philadelphia chromosome, so translocation 922, which means that BCR-ABL fusion has occurred, and that increases tyrosine kinase levels. So the treatment is going to be a tyrosine kinase inhibitor, which all of us know by the name of imatinib mesylate, and that is most important for FMG exam. All cells are mixed, garden party appearance, college girl appearance, because now before moving to the next question, you will tell me, where do you see the convent school girl appearance, which means that all the cells are dressed in the same uniform. All of them look like this, lymphocyte, lymphocyte, lymphocyte. So that is going to be a case of CLL, and some of those lymphocytes are also broken and smudged out. So those are known as the smudge cells that you see in CLL. Take home message, convent school girl appearance in CLL, and this garden party appearance is going to be seen in CML. Moving on to the next question over here, where there's a 5-year-old boy presenting with weight loss, fever, and a painless swelling in the area of the jaw. CBC reveals anemia and lymphocytosis, and biopsy is shown. I hope you could see that the dark background is the sky and the white cells in between are going to be the stars which are shining. So that is the starry sky appearance. Now read 5-year-old child with a jaw swelling. It goes in favor of Burkitt's lymphoma. What was missing over here was that African child. If this photo would have come, then you would not have been reading the question. So they started omitting the word Africa nowadays because that has become such an important buzzword, so they hide that information. Usually it comes as a child with a jaw swelling and starry sky appearance. Africa holds the significance that it is associated with EBV, and EBV is endemic in Africa, and that causes Burkitt's lymphoma. What is the other way of having Burkitt's lymphoma is translocation. 8 and any even number like 8 and 14 chromosome, or it could be 8 and 22, or it could be a smaller number than 8, but it has to be even. So 2 and 8 would also do. On a biopsy, we see the starry sky appearance. The background is dark. That is the tumor cell, which is the sky, the dark background. The stars are nothing but the innocent macrophages who've come there just for eating things around. So starry sky appearance. Moving on to the next question, diagnose the blood group. For diagnosing the blood group, the simple take-home message is wherever you have to see, first look out for control. The control should be clean. The control sample should never be clotted. If the control sample is showing clots, this means you have collected the sample in a manner which was incorrect and you don't have to read the report. The control should be clean, no clot, so it's fine. Now, wherever you will see the clot or agglutination, the agglutination will tell you the blood group. So you are seeing the agglutination clumps over here with anti-A, so the blood group is A. You are not seeing any agglutination with B, so there's nothing to do with B antigen. You are seeing the agglutination with anti-D. Anti-D tells you about RH, that is positive, negative. So if you're seeing the agglutination, it is positive. This becomes a case of A positive. So simple rule is if you would have been seeing the agglutination here also, then it would have become AB positive. If you would see agglutination only in these two, it would become B positive. If you would not see agglutination in any of them, only in positive, but not in A and not in B, then it would have been O positive. And when you stop seeing agglutination in anti-D, then those start becoming negative blood groups. Like over here, if only A would have been present, nothing else, then my answer would have become A negative. So where you see the clump and the clotting, that is what is the blood group over here. Moving on to the next one, preferred anticoagulant. I know what you always go for is that, okay, if it's gray, then it is used for everything to do with glucose estimation. Glucose estimation has two components. One, you have to stop the blood from clotting, and that is what is asked. The anticoagulant used over here is not sodium fluoride, it is potassium oxalate. The anticoagulant is potassium oxalate. What is sodium fluoride? That is an additive that will basically stop the glycolysis from occurring, but that is not the question asked here. They are asking you what will stop the blood clot, and the answer is potassium oxalate. So this has two things, potassium oxalate to stop the clotting and sodium fluoride as an additive to stop the glycolysis. Anything to do with sugar estimation like fasting blood sugar, postprandial blood sugar, random blood sugar, glucose challenge test, glucose tolerance test, any other glucose test that you know of, but please never ever put HbA1c in this, because glycated hemoglobin also tests the hemoglobin element, so that shall go in the lavender purple Vacutainer, which has the anticoagulant EDTA. Moving on to the last question of the day, which of the following is least likely to be affected in GVHD? So now what is GVHD? GVHD stands for graft versus host disease, something to do with transplantation. Whenever, let's assume a kidney has been transplanted, what we always focus on, kidney has been rejected, transplant has been rejected. So all your focus is that the kidney or the transplant rejection has occurred. So let's assume if this is a human being and you have actually put a kidney inside this person, your main focus is that this person has said kidney has been rejected. What if it's the other way around? What if the person accepted the kidney, but the kidney has gone and started attacking this recipient? So what I analyzed over here, that the graft kidney that you have put, that is very, very strong. That is immunocompetent. It has a lot of immune cells. And this poor host of yours who is being killed, that hardly has any immunity. This means that person is immunocompromised, and now that is the reason that this kidney is now going and attacking this person. So the question is that when will this occur? If this occurs within 100 days of the transplant, it is acute GVHD. If it occurs after 100 days of transplant, it is chronic GVHD. And which are the organs of this patient which are getting maximally attacked? It is the skin, the intestine and the liver. In the skin, patient will have rashes. In intestine, there will be diarrhea. Liver related jaundice will be there. So the question is, which organ is least likely likely to be affected in GVHD? Skin, intestine and liver is obviously affected. So what is least likely to be affected is the lungs, and the answer over here, it's a very famous PYQ of the FMG exam. Of course, with that, we wrap up today's session. We've done approximately 14-15 questions. And now you have two homeworks. One is ATP7B was for Wilson. So 7A is what you tell me. And what are the cells in canals of Herring and what is their function? So these are the two homeworks for the day. I'll be meeting you tomorrow with the final day of this series, where I'll also compile all the 10-day PDF and put it across to you. And yes, of course, that is when we'll wrap up, because now I don't want any more sessions closer to the exam. So tomorrow will be the final one. And of course, best wishes coming your way. So complete the homework and see you tomorrow.